Hey, Danny, this is Mark. Can you hear me?
Yes, sir.
Okay, we'll get started in 8 minutes then. Hello, everybody. This is Mark Lynn. We're going to get started in about 7 minutes or so. Since you're in here early, if you want to download the presentation is in the handouts box. We have 5 handouts in there, and then we'll show you links to get other handouts as on cost reporting that's on our website as well. But we'll get started in about 7 or 8 minutes. Okay. Just got a question in the question pane. Danielle's asking about the depreciation PDF is not opening. Not sure what the problem is. I'll show you the link in a minute whenever we go through the presentation on our website. Click on it and hopefully it works there. So if it sometimes for some reason when you put them into GoToWebinar, the links don't really work that well. So we'll see if we can get it to open up on our website. We'll show you where that is whenever we get ready to do the presentation. We'll be starting in 4 more minutes. And if you do have questions or comments, you can use the chat box or the questions feature there. Danny Gilbert and Trent Jackson will be watching those for us and will give me a little bit of a heads up for those types of questions. We will have some time at the end for questions. Welcome home. Hey, Daryl. It's great to be home. Hello, everybody. It's 3 p.m., which means it's time for the RHC Cost Reporting Year-End Planning webinar to begin. It's presented by Healthcare Business Specialist, and we'd like to thank our sponsors, Azalea Health and ChartSpan, for sponsoring this educational webinar for you that is presented free of charge on December the 9th, 2019. My name is Mark Lynn. I'm a CPA from Chattanooga, Tennessee, worked with the RHC program for 30 years or more. Here's my contact information if you need to get a hold of us. Danny Gilbert is with us as well. She's a CPA that works on our cost reports and TennCare quarterly reports and 855As, RHC startups, that sort of thing. So Danny does pretty much everything. She'll be online as well, monitoring this, and she'll be, since she works so much with this cost reports, she's the one you got the emails from as far as our agreements for doing cost reports. Danny will be chiming in and helping us get through this as well. Trent Jackson is also an intern with us, and he is on the line as well, and he will be helping prepare cost reports for us again this year. What do? We prepare Medicare cost reports this year. Thanks to you guys, we're going to do about 175 cost reports. That will be a record. We're closing in on 200 cost reports per year. So that's a really good number for us. We appreciate your confidence in us. We also do a lot of RHC startups, program evaluations that now only to be done every 2 years. Emergency preparedness regulations. We do a lot of emergency preparedness work with our RHC clients. And of course, Danny does about 12 of the TennCare quarterly reports that are required from our TennCare our Tennessee RHC clients. If you want a brochure about our cost reporting services, this link will take you to that brochure. Also, the brochure is over in the handouts section of the GoToWebinar over here. There's 5 different presentations on there. Our slides over there. The actual presentation we're using is in there as well. So they should have working links in that PDF that you can use. If you do have an issue there, I know Danielle mentioned that the one on maybe depreciation and startup cost was having a problem loading. We will show you where there's a place where you can find that on our website as well. Excuse me. If you've not joined our RHC Information Exchange group, it's probably where you guys heard about this. So you're probably a member, but if you haven't become a member, please become so. I think we're at 937 members, so we're closing in on 1,000. We would love to get to that 1,000 number here very, very soon. But it is a great place for you guys to ask questions and get comments. And there's a lot of people that provide really good information on there. Besides Danny, besides myself, there's a lot of other consultants that freely give their time answering your questions. We still have one more of the free seminars is available, Clinton, Alabama on 1/16/2020. It is really, really, really going to be tight getting anybody else in that building though. So if you want to go, open it up a little bit for a few more extra people, but it's really going to be close. We have a packed house in that particular location there. There's what the schedule looks like. On those seminars, we'll start about 9. We'll finish up about 3 to 3:30, and there'll be a lot of billing. And the one in Alabama, if you're from Alabama, this 11 o'clock session here has been replaced by Tori Nix from Alabama Medicaid. She'll go over RHC Medicaid billing for 1 hour. So that will be a really good opportunity to ask questions about Medicaid billing in the Alabama session. If you don't have a chance to go, all of our documents and seminars, again, they're free. You can find those on this Google Doc here. And then we've also put together a Google Doc on converting into becoming an RHC as well. And you can go find all that information. There's a lot of good information in there, especially about preparing for the state inspection. Even if you're already an RHC and you think your inspection's about to come up pretty soon, this is a good document to go in. It has a lot of really useful links, and we spend a lot of time pulling this thing together for our people that are converting to a rural health clinic. So I think that would be very helpful to you. This information is updated as of 12/9/2019. So I worked on it. Believe me, I worked on it very hard at the last second. I've been out of the country. Most of you know, I've been out of the country for the last 13 days, and I've just gotten back this weekend. For you guys that know that I've got my cell phone stolen in Barcelona, I do have my cell phone back now. I got a new one now, and so you can call or text me now. I've been sort of out of touch for the last 10 days or so, which has frankly been pretty nice. But getting into our actual presentation, the RHC cost report overview. Why is it important? Is because if you don't do this, then Medicare will not pay you. They will actually take money away from you. So they'll take the money away from you at the end of the year. So it is very important. Also, your Medicaid, your TennCare rates, if you're in Tennessee, are based upon these cost reports. So especially base year cost reports are very important when you first become an RHC. It's important that you get somebody who's very familiar with the state that you're in and is familiar with how Medicaid establishes those RHC reimbursement rates. These cost reports will settle your flu, pneumococcal, bad debts, and there's some money in there for preventive and copays and deductibles in there. So there's some money in there that you can recoup from Medicare by preparing these cost reports correctly. And you are responsible for preparing these cost reports accurately and in compliance with Medicare and Medicaid regulations. So you want to know these rules and make sure that somebody is, whoever's preparing these for you and you guys are signing, you're going to be ultimately responsible. So it's important that you have somebody who's very familiar. And there's very good people out there to help you prepare these cost reports. We will be talking about the independent cost reports because that's what the 175 cost reports we do will be all independent cost reports. If you are provider-based and you're part of a hospital system, this information will be valuable to you in that the cost reporting forms are essentially the same. What provider-based cost reports do, they use form 255210. They use the M series, and they basically have the same exact forms. You can see we had a crosswalk here of the forms, and you can see it's basically the same forms. There's a few that the independent cost reports were updated in 2017, while the provider-based cost reports have not been updated since 2010. And so there's a few new forms in the independent RHC cost reports that you don't have in the provider base, but for the most part, those are exactly the same forms and you capture exactly the same information. The one thing that a provider-based RHC would capture that an independent would not would be statistical information, square footage, central supply, accumulated costs. The way the hospital cost report works is there's a step down method where it allocates costs to the different cost centers. And that's how you pick up your facility overhead piece. And you want to make sure that you do those statistics correctly because that's usually between $80 and $90 per visit of additional overhead and additional cost that you will pick up by doing those statistics correctly. So that's one of the most key parts of your provider-based cost reports. The cost caps per year, if it's an independent RHC, you are capped at a very, very low rate. I've not heard yet if we got an increase. I know we talked about this RHC Modernization Act that we're hoping to get through. As of today, I've not heard of the legislation passing for that. If you guys know something, please let us know. We'll be glad to pass it on. That'll be the best news ever because we're talking about getting the rate increased to $115 per visit. Right now, it's capped at $86.31, which we all know is woefully low. Your cost per visit is probably around $115, $116 a visit. So you're taking a $30 haircut for every Medicare patient that you see. These caps are applicable to all independent RHCs. And if your provider-based RHC is 50 beds or more, then They are subject to these caps. If your provider-based RHC is less than 50 beds, then there is no cap on your reimbursement from Medicare. It's 8631 does not apply to you. So keep that in mind. Also, this link here, this tiny URL, that is the new MedLearn Matters document that gives the rate. The 1.9% rate is actually the largest increase we've gotten in probably 20 years, which is that's one reason why these rates are so low. They've not kept up with the consumer price index by any means, and that's why we've gotten so far behind. Excuse me. Here are the items that the Medicare cost report settles, the difference between the interim and the final rate, and that is a little bit trickier than it used to be because the max will now pay you more than that capped rate of $86.31. You can actually have a interim rate of $95, $100. I've seen it be that high, and they will also pay you interim settlements as well. So that's a little bit trickier than it used to be. The flu and pneumococcal reimbursement is very, very good. On average, the flu shots get paid about $60, $65 per flu shot. Pneumococcal shots range in the $250 to $300 range. Of course, Prevnar 13 and 23, that cost your cost is usually $180 for the 23 and $90 for the 13, or it could be the other way around. But your cost is very high for those, and the reimbursement is a cost-based reimbursement, so you do get paid very well for those. And then Medicare Bad Debts, if a patient does not pay their copay or deductible and you make reasonable collection efforts, then you will be able to claim that money on the cost report. The key to that is it has to be written off in the fiscal year. So if you guys are a 12/31 fiscal year, your homework is to go back and look at your Medicare Bad Debts and write those off before December 31st, because if you write your Medicare Bad Debts off in May when your cost report is due, you're not going to be able to claim that on that cost report. It's going to be on the 2020 cost report. So if you want to file for your your Medicare Bad Debts on your 2019 cost report and you're a 12/31 year in, you have until 12/31 to write that off. It's cease all collection efforts. That means you can't turn it over to collection agency on 12/31 and say you've given up trying to collect it. That means you cease all collection efforts, even turning it over to the collection agency. And then there is a little piece in there for your copays on preventive services that you pick up as well. So it's very important that and that's driven based upon your charges. So it's very important that if you're doing those G codes for preventive services, that even though you don't see any change in reimbursement, say you have a sick visit and you also do a smoking cessation visit at the same time, you would say, well, I'm not getting any more money from Medicare. But when we file the cost report, it actually averages for every charge you put on there, you get about 17% additional reimbursement from Medicare. I'm not sure how that math ended up being there, but I know from just looking at the numbers and kind of playing with it a little bit, that's what I've come up with is the additional money. So you want to make sure you code that. Number one, it's a frequency limited. Preventive services they have frequency limitations on them. And so number one is you want to make sure that you get that into Medicare so that they know what those frequency limitations, if they've hit those or not. And number two, of course, is for you guys to get paid for your services there. And if y'all try to ask me how to explain how they do this, I'm going to just give you a dumb look, because I know it works, because I know we've done enough cost reports and I know we've played with them enough. But if you ask me how they come up with that number, I've done it a few times and I really can't figure it out. Okay, so cost report repayments to Medicare. Last year, probably 30% of our clients had to pay back money to Medicare. And the reason, and this never happened before, I know a lot of people will say, Mark, why'd you mess up our cost report? We didn't get as much money as we did before. And we've had when we go to the National Association of Rural Health Clinics meetings, we go to those there's 2 of those each year. We go to those every year. And we talk shop with the other cost report people, and they're like, yeah, everybody is upset. mean, to me, it's a good thing because Palmetto, CGS, a lot of the different MACs have went ahead and started paying you guys more than your reimbursement rate. The reason, the capped rate, the reason for that is they're trying to get your money up front so you can pay for your flu and your pneumococcal. We complain so much about waiting 2 to 3 years to get your money from Medicare for your flu and pneumococcal shots that Medicare finally did something about it, and they're paying for you guys through that interim rate. The problem is it's pretty hard to estimate how many flu shots you're going to give, how many pneumococcal shots you're going to give, and how many Medicare visits you're going to have in a year. And so those are the things that they use to estimate that. And what Palmetto and what CGS will do is they'll write you a check for $15,000, $25,000, $40,000 as an interim settlement ahead of time during your fiscal year. And we need to know what that interim settlement is because we have to put that on the cost report. If we don't put that on the cost report as a payment, we're underreporting our payments. And then when Medicare comes in and does their desk reviews, they're going to find it very, very quickly, and you're going to end up paying not only, what will happen is what tends to happen is you'll get a tentative settlement. Say we get a $20,000 interim settlement, but we don't know it, and then we file the cost report, and it shows that Medicare owes us $20,000. A lot of times Medicare won't notice it either, and they'll pay you that $20,000 as a tentative settlement, and then when they come into final review and look at it, they're like, oh, we sent them one interim settlement during the year, and then we send them another one, and that doubles it, and you end up having to pay back Medicare that money. So you're not doing yourself any favors by not sending us that sheet of paper. So please send that to us. It will result in, and when you do send it to us, your settlements from Medicare will be much lower than they have been in the past. Again, that's a good thing because you're getting your money up front. You're not waiting 2 years, 3 years to get that money. So I know it's a little bit confusing to people, but that's what's been happening in the last year or so. So for update for our clients here, I know for you guys that are our clients, this may be a little bit dry and maybe not apply to you, but probably all the other cost report people that will have a very similar process to what we have. At least I hope they do. And Danny's gone out and she's already emailed, I think, all of the cost report agreements out with a business associate agreement. There is HIPAA information in your cost reports. You're going to have Medicare Bad Debts. You're going to have influenza and pneumococcal logs. So we will sign a HIPAA agreement with you that we will protect your data. Everybody here knows that we have to shred everything. We take everything over to the shredders and get rid of it that way, and we will protect your information that way. We will be providing more and more webinars and seminars, and we're thankful that Azalea and ChartSpan has partnered with us we'll be doing some more. And I know Georgia, we're definitely going to do one in Georgia. And there's a couple other places that we plan on going with seminars in 2020, besides our normal route of Nashville, Alabama, and Kentucky. That's probably the majority of our clients are there. It does seem like it was just yesterday when we were working on cost reports last year. It turns around super fast. If you watch for Thanksgiving, which we always do, they tend to, the little elves celebrate that they just got Christmas Day over, and then they start working again for the next Christmas. That's exactly the way it feels. And the picture of Will Ferrell here is exactly what I look like in grammar school, if you know me. So I'm 6'9" if you don't know me. So here's the process. Number one is sign the agreements and send in the retainer check. We ask for basically half of the fee, and then we'll bill the rest of it once we finish the cost report, typically in late April or early May. You will receive that cost report checklist from us. That cost report checklist is in the 5 handouts over there. And then from that, you will obtain the information from the checklist and make sure you get your PSNR if you can. We'll will tell you about how to get that as well. Once you get all that information together, mail it, fax it, email it to us, any way you can get to us. If you have a ton of information, we have Dropbox, and Danny can set up a special folder for you where you can just deposit all your information in there as well, if that makes it easier for you. Most of the stuff should be coming directly to Danny's address in Cleveland, Tennessee. And so you want to send that to her. Don't send it to where we have to sign for it. That tends to slow things down because we have to go drive 30 miles to go to the mail-in office, the post office, and get that. So just send it that way. Do make a copy of it, of everything you send to us. Make a copy of it before you send that to us, and then we will prepare your cost report, and then we will actually mail it back to you. You guys have to be the ones signing this thing. We don't sign cost reports because you are the authorized person to sign that, and then you will mail that to Medicare and Medicaid. There is a new system now called MCREF, and we'll talk about that, where you can do everything electronically. And so that may be, we'll talk about if you guys can get us set up as an authorized signature, then we could actually file your cost report completely electronically, and you will not have to sign that. Danny or myself will have to actually, there's a little button there that you click. I have filed one electronic cost report in my day, so I wasn't the authorized person, but we did it anyway. And so sign the cost reports and get those mailed to them. Remember, and don't mail. We've had people mail them back to me, and then I have to just get them right back and stick them back in the mail. And we don't want to miss a deadline because of that. And then once you get your cost report filed, you'll receive your tentative settlement within 90 days of filing. And then Palmetto and CGS are really good about reviewing your cost reports within 1 year. I know if you guys have been around with Cahaba was 3, 4, 5 years behind. It was ridiculous. So that is sort of the schedule there. Here are the mandated cost reporting time frames. This comes from Chapter 8 of the Financial Integrity Manual that Medicare puts out. You're required to file your cost report within 5 months of your year end. So that's going to be May the 31st. We have to have this cost report postmarked by May the 31st, or they're going to start cutting your payments off. You will not get any payments paid to you after that, and until you file that cost report. And if they paid you any money during the year, I know we had one clinic where I think they paid them $200,000 or $300,000. They basically will ask a demand letter, and they'll actually do nasty things to get that $200,000 or $300,000 back if you don't file that cost report. So you have to do that. Again, Medicare has 30 days to accept the cost report. What you want to do is get this cost report filed before those 30 days. You want to actually get it filed 1 month ahead of time if you can, because what happens is we file 175 cost reports. I'd love to tell you that we are perfect. I'd love to tell you that Palmetto and CGS is perfect and nothing ever gets lost in big old huge insurance companies, but it's just not true. Things happen. And what will happen is they will call us. Everything is done by email these days for the most part. Occasionally we get a phone call from them, and they will tell us that they'll say, Mark, we're missing certain files. Electronic file is missing, and we'll send you a USB drive. Do not hang on to that USB drive. I've had 2 or 3 people last year that said, well, we like that USB drive, so we just hung on to it. I'm like, no, that is your filing of the cost report. It says on there Medicare. We get a big stamp on it. It says Medicare on it, and so that's the electronic filing of the cost report. So hang on. So send that to Medicare. Don't hang on to it. Send it to Medicare. Try to get these cost reports filed before 30 days before the due deadline, and then that will save us a lot of trouble of getting your payments cut off. The number of days that Medicare has to send out a tentative settlement is they have 30 days to accept it and 60 days to send out the tentative settlement. So you should be getting a tentative settlement sometime in September, sometimes in August, sometimes in October. And then they have 1 year to do the final, from acceptance to final settle. That's what's called an NPR. And make sure that the MAC is up to date on if you have any changes of people there. There's a form, and we'll show you the link to the form here in a minute. Make sure those email addresses are up to date. So if you've had changes in administrators during the year, you want to let them know what the new address is, because a lot of times, and we've seen big issues there where people didn't let them know, and time frames and audits and things like that happened, and it was bad things happened to those clinics. So here's the things from y'all's standpoint as a client, as a clinic, as an RHC clinic, you have to know before you're in. Number one, if you're claiming Medicare bad debts, you have to write those off by the end of the year. If you're a 12/31/2019 year end, write those off. So again, your homework is to go back and look for those Medicare bad debts. Number two is if you're in what's called a base year for Medicaid, a lot of times we will accrue bonuses to the owners. A lot of times you guys are brand new RHCs, and unfortunately your money has been slowed down because you haven't been able to get your rate set from Medicare and Medicaid. It is a slow, I always call it the trough of disillusionment, or the valley of despair that you go in when you become an RHC and you're all excited, you're going to get all this money, and it takes 3 to 4 months to get enrolled with Medicare. And Medicaid, it takes 3 to 4 months to get them to set a reimbursement rate. And so your billing basically gets frozen for close to 4 to 5 months, and it takes a while to recover from that. And so we will end up accruing bonuses to owners. Those have to be liquidated within 75 days of year end. So if we accrue Danny a bonus of $25,000 to be paid within 75 days of the year end, that has to be liquidated in order for us to claim it on the cost report. If Trent is a office manager and we accrue Trent, he's been done a fantastic job for us, we accrue him a bonus of $10,000. And he's a non-owner, he's not related to anybody, then we have up to 1 year to pay him that $10,000 bonus. So we tend to use those during base year cost reports because we're trying to get our cost per visit up for Medicaid services. Now we follow all the Medicare, all the Medicaid rules on accruing those bonuses. So if you're doing those, you want to be very careful with those to make sure that those are allowable expenses. Also, you want to get signed up with EIDM, and used to be called IACS, to get the PSNR. The PSNR report is a provider statistical and summary report. It tells how many Medicare visits you had during the year. It tells how many, what the charges were, what the co-pays were, what the deductibles were, and what the net payment was to the clinic. And you want to ask for a type 710 and a 71S. And those two reports, and you want to make sure you ask for the summary. Don't ask for the detail. If they start talking about sending you a CD-ROM, go back to where you started from. You just want a summary. They're going to give you, it will basically be a 2 to 3 page PDF is all that we're looking for. So also, if you want us to use MCREF, then you're going to want to make Danny Gilbert as your authorized cost report preparer, because I did not turn on my camera there, but you saw the picture earlier. I'm old as the hills, and Danny is young, and Danny's technically technically oriented, so she will be able to do those for you guys, and so make sure that Danny is the one that's authorized cost report preparer for the MCREF system. And then make sure you get your cost report submission early into us. If you don't use us, get your cost report submission in early to whoever prepares your cost report, because they're going to be just like us. They're going to be swamped during that time of year when we're trying to get all these cost reports done. This is the way it's supposed to work here. Here's Julie Quinn. If you guys know Julie, Julie's wonderful. She lives about a block away from me. She prepares probably 2 to 3 times as many cost reports as I do. And so she's over here. So like I said, she lives about a mile from me. And this is on May the 29th, a few years ago. Her Facebook post was she's feeling relaxed on May the 29th. And of course, the cost reports are due by May the 31st. That's the way it should work. This is what I posted on exactly on the same day. I've forgotten what it's actually like to have a normal sleeping pattern. So don't wait till the last second to send these things over. I can tell you the cost reports that we have the biggest problems with are those ones that come in late. We're working day and night, probably from April until May the 31st, and we're in this what I call the emotional exhaustion state at this very end. So you want to really try to get this on this curve here. You want to get in very early, because what will happen is we will be able to identify issues like Medicaid base years. We will spend more time on Medicaid base year cost reports because it's going to follow you forever. There is the ability to file low and no utilization cost reports. And we're going to talk a little bit about those and get some planning for those, because I mean, what I'm going to tell you about the low utilization cost reports will probably shock you in a minute. And then obtain your PSNR. You have to get that started soon, or it will not get done. I mean, let me tell you, it takes 2.5, 3 months at least to get through the EDIM system and submit all the information that you have to. And then again, you get your 1231 time to write off your Medicare Bad Debts, and then submit that data time as you prepare. So we have time to prepare it, review it, get it all pretty, and send it all out to you guys. So it's very important that you do that. Okay, here's some of the new items that we have. I've been talking a lot. Danny, do you have anything to say so I can give myself a little break here on talking?
I do not, but there are a few questions if you want to go ahead and take a look at those.
Okay, all right. What you got?
Okay, the first one's from Debbie Bonds, and she says, our clinic is not seeing patients at this time, so we don't have to file a report, do we?
Our cost report, our clinic is not seeing patients at this time. We don't have to file a cost report? The answer to that is depends. And I can go through all sorts of scenarios. Debbie, just email me and we will talk about, or call me and we will talk about what your situation is, because I mean, even though you're not seeing patients, you could still be in the you could still be in the Medicare RHC system, and they're going to require you to file some type of cost report. And again, that's where the no utilization cost reports could come into play with that. So just to blanket say, oh, because we're not seeing any patients, we don't have to file a cost report. That's not true. If you're in what's called the STAR system, Medicare is going to bug you to death to file a cost report. Okay, next question.
And then Barbara Conway, I have not received the agreements. Barbara, I actually just re-emailed those to you because I saw your comment. So I've resent those. If you still don't have them, shoot me an email.
Okay.
Danielle says, would you be coming to Florida for a seminar?
Would I be coming? I'll come to Florida just because I'll be there. I'm leaving Wednesday to go to Florida, come to think of it. So, I don't know. We may do one in Florida just because I love Florida, and we're doing some startups there. So we'll see about that. That's a good idea. I'll talk with our sponsors, with I forget the names, Chartspan and Azalea, and who knows, we may go there. Any others?
And then the last one is from Kelly. Is there somewhere that I can get a copy of this presentation?
It's in the,
go ahead.
Yeah, it should be in the handouts there. So should be the third one. So our 2019 RHC cost reporting year-end planning. So that's where it is. Okay. And that was the last one.
That's all your questions. Now, Barbara has her hand raised, but I don't know if that's because she had the question that she typed in or if she wants to say something else.
Oh, Miss Barbara. Okay, well, let me Barbara, I am going to unmute your line. Hey, Barbara, how you doing?
She come tomorrow because I didn't really want to take my career to she was like.
Oh, did you hear that, Danny?
No, I don't know if she's talking to us or if she's talking to somebody else.
Okay, all right. I'm gonna mute Barbara's line, and then if Barbara wants to ask a question, she can just put it in the question mark, say, unmute my line. If she'll do that, that'd be great. Okay, because we got a lot to do. How much time have I spent here? Yeah, I spent a lot of time. Let me see here. So let's go. Here are all the documents that we just put this on our website here. So if you go to ruralhealthclinic.com, you'll see here, this is what it will look like. And then once you get on there, excuse me, you'll be able to get, there's all sorts of documents on here. And there's the actual presentation from today. Excuse me. There's our cost reporting brochure. Which was the one that they said, this one here, I think somebody said they had a problem with it opening. Let's see if it opens here. There you go. So there, and you can see what a dry life Danny and I live. These are all the depreciation regulations here. So there is the document there. There's that will take you to all the documents that we are using in this presentation as well. So, and then there's a lot of good, if you're in Kentucky, there's one on base year cost reporting, which is a nightmare. There's one on Tennessee. There's a lot of changes in Tennessee as well. And so here's the Tennessee cost reporting base year document planning as well. Most of you guys will use Palmetto GBA. You're the JJ contract, and then we just went to their website today just to see anything new that they have here. There's a lot of the email addresses that you need as well if you're filing with Palmetto. So you want to keep those in mind. Typically, when we start doing the cost reporting and getting ready to do cost reports, is the first thing we do is you want to look at the Medicare website to see if there's been any changes or addresses, especially the addresses change every year is where to mail these things. And you want to look at the state websites as well. I know North Carolina, Joy Lou, they will tend to change the North Carolina cost report forms every year. So you want to make sure you get the latest forms depending on which state you're in. And then here's some of the items that they tell you about what you should be doing. This is from the Palmetto one. Again, file early. That's very important that you do that. And that way you won't get your payments suspended for the due date. And it gives we follow these rules on putting together all the documents. When you get the documents from us, the ones that go to Medicare will be on a little binder clip. We don't staple or we don't bind it in any way. And then your copy will be in a nice little leather bound booklet, and that's your copy. So if you see a leather bound booklet, that's yours. If you see a little binder clip, that's going to Medicare or that's going to Medicaid, because they will typically scan things. Even though we scan all of our documents and we put those on a USB drive for you guys to have, so you'll have a scanned copy of it. You just want to make sure you do that. This is something that's brand new for you guys that are writing off Medicare bad debts. When you write those off, and I don't know why this matters, but apparently it matters to Medicare, is you're not going to write it off as a contractual allowance account. It's not going to be a reduction in your revenue, but it's going to be a bad debt expense. So it has to show up in the expense side of your accounting. So you guys go back and talk to your accounting people. Make sure that whenever you write off a Medicare bad debt, it goes as an expense and not as a reduction in revenue. Otherwise, they're not going to allow it as a bad debt starting on and after October 1, 2019. So the way I read that, Danny, you correct me if I'm wrong, is that's not going to apply for these 12/31/2019 cost reports that we're doing, but it will apply to the 12/31/2020 cost reports. Is that right?
That is how I read it.
That's the way I read it too. So it doesn't. It's not going to affect you guys yet as far as your 12/31/2019 cost reports go. But you need to start working on your accounting to make sure that you put this in the right place. Especially, I think the one big adjustment that most people make is if on Medicare, if it was what's called dual eligibles. And Medicare is your primary and Medicaid is your secondary. Medicare pays, it's $100 charge. There's a $20 copay. That $20 copay crosses over to Medicaid. Medicaid says, okay, we'll pay you $8 of that, but that's all we're going to pay. That $12 that they do not pay, it's not a contractual adjustment. It is a Medicare bad debt that you can claim on the cost report as a bad debt, and you want to include that as an expense. So you want to make sure you capture that, because I know, so depending on which state you're in, a lot of states that is a pretty big number. Here are the MCREF regulations there. So this is for Danny and for Trent. Is you guys will need to probably read all this sort of stuff here. And if you guys, when you go into the EDIM system, is you're gonna want to make Danny as your authorized person, or if you use Julie Quinn or David James, or like I said, there's lots of really good cost report people out there. You want to make that person be your MCREF, your Medicare authorized person there. So, Danny, have you got that all figured out yet? Or are you still working on getting that figured out?
Still working on it.
Still working on it. Okay. All right. Yeah. Good. All right. Well, there's your homework, Gaines. Make sure everybody understands that it's nice to be able to assign homework instead of having to do homework. And then here is a MedLearn Matters on the MCREF system as well. There is a presentation that they did back in May of last year, and then there's another one that did in October or December, sometime very recently while I was away. It happened, and I haven't got to see it yet where they've updated the MCREF stuff. So Danny and I and Trent will need to watch that. We'll get a chance. Here is the document that Palmetto uses to update their information. So you want to make sure that these contact information is updated. Again, we get a lot of emails from Palmetto, CGS, Novitas, where they're sending in adjustments and different work papers related to your cost report. So make sure that we're included on there and that we can respond to those in a timely fashion. So, and in cost reporting, it is basically your invoice for services. That's what the cost report is. There's 3 types of cost reports. I'm going to have to speed up here. We may actually have to have another session of this because I'm going so slow. You can be a no utilization cost report if you have no Medicare. If you're a pediatric office, it works great. You can file a no utilization cost report. You basically sign your name on there and promise not to try to collect any money from Medicare or send them any bills, and you're good to go. There's something called a low utilization cost report, and the number is this is the shocking part. The number is 200,000. Cahaba, when they were doing it, they put in their document that if your Medicare charges were over 25,000, you could not do a low utilization cost report. When I look at Palmetto's numbers, and I made a screenshot of it for you guys so you can see it, they say it's 200,000, which is an astronomical number. And so most 95% of the RHCs would qualify for a low utilization cost report. Of the 175 cost reports that we do, probably 95% of you guys would qualify for this. That's not saying you guys need to be doing those, because you're giving up a lot by filing a low utilization, and we'll show you why that could be a problem. Your full cost report or $200,000 or more in Medicare charges. So we have very few. So let's go into no utilization cost reports real quick. Is basically, again, this is for pediatric practices. In Tennessee, you are required to file a full cost report, whether you're no utilization, low utilization, or full utilization. I call that the Mark Lynn Full Employment Act right there, because that keeps us, that we end up having to do a lot of cost reports that normally we would not do in other states because of Tennessee law. And if we've tried to sort of skip by and not do a few of them, and they will make you do them. I was crossing my fingers on a few of them, hoping they wouldn't make us do it, and they will make you do those cost reports. Here's the low utilization cost reports here, and it tells you the instructions on that. There's that 200,000 number there. Here's the actual screenshot of Medicare of Palmetto saying that the number is $200,000 and what you have to do, which is next to nothing. You have to sign in a sheet by the office of the provider, provide them a balance sheet and revenues and expenses and a trial balance for the period, submit that to them. And here's the catch. You're not going to get paid any flu or pneumococcal shots. So if you give those $200 or $300 flu and pneumococcal shots, you ain't going to get paid for them. Your co-pays and preventive services that you get from your co-pays and preventive services, you're not going to get paid those. Your Medicare Bad Debts, you're not going to get those. And the difference in the interim rates and the final reimbursement rates, if they underpaid you during the year, you're not going to get paid that as well. So you're giving up a lot to file this low utilization cost report. And I can't see very many of our clients. It's probably a math number. It's if you don't do any bad debts, you don't do any, any flu or pneumococcal, then the $2,000 fee or the $2,500 fee or the $5,000 fee or the $4,000 fee, the fees are all over the place on preparing cost reports. That fee, you can sort of look at that and say, oh, okay, we pay these guys this X amount of dollars to do the cost report, and our Medicare bad debts and flu shots are less than that, then, or more than that, then we need to continue doing cost reports. If those numbers are less than that fee, then you may want to think about doing low utilization cost reports. Again, that's why it's good to get started early so we know what you're doing, and then next year you will know, hey, we're going to be filing low utilization cost reports, so we're not going to do flu and pneumococcal because we're not going to get paid for them, and we're not going to fool with Medicare bad debts because we're not going to do for them. So you can plan ahead if you know what those numbers are, and so keep that in mind. Also, base year cost reports for Medicaid, 346 here. I don't have much time left. Remember, if this is your first full year in the RHC program, most states will require you to have a base year cost report, especially in Tennessee. In Alabama, that cost report is a special form, and you start the day you're certified as an RHC. So you want your cost to be high, you want your visits to be low if possible. There's really not a lot you can do. I always tell people, pay yourself as much as you possibly can. Make sure you get all your expenses in there. Borrow money if you have to. You have one shot at this to get your expenses up as high as possible during this base year. And this is only, I know for Kentucky, Alabama, and Tennessee, they all have systems like this. So if you're in any of those states, let us know, or let the person who's preparing your cost report know that you're in this base year cost report, and that you really need to get this cost per visit as high as possible, because they only do it once. And so you want to make sure that you do that. You will probably lose money during that base year as well. But if your Medicaid rate is really, really good, attractive, it will stay that way for the next 10, 15, 20 years. So you want to do that. Okay, I'm at 3:47. So to give us some time to get you guys out here, let me see. Let me look through real quick and make sure. What I did was I just left in the slide presentation that I did for the National Association of Rural Health Clinics and HRSA back in July, so you can have a lot of these documents here so you can see how this cost report is done. I'm not going to go over those today. I really just wanted to give you sort of an update on the things that are very important as far as year-end planning goes. Productivity standards. One thing, let me tell you about productivity standards. For physicians, it's 4,200 visits for a 40-hour week. For nurse practitioners and PAs, it's 2,100 visits. That's a minimum productivity. If you don't hit that number, it could affect your cost per visit. And so what we want you to do is keep up with your time. There's a time study that you can do for them. The key is make sure that you identify time seeing patients, not and RHC patients is what we're looking for there. So, and if a physician is only working 2 days a week, he's not a 1.0 FTE, he's a 0.40. If you have a nurse practitioner and he's only working 1 day a week, he's a what is that, a 0.20 versus a 1.0 FT. A lot of people mess that up, and those productivity standards can hurt them. So you want to talk to us about those productivity. If you don't understand those, keep that in mind. Productivity standards. There's what Medicare bad debts. Remember, Medicare copay, 20% of charges. That 20% you can get as a Medicare bad debt. It's only things that are billed to Medicare Part A. Anything you bill to Medicare Part B or any other type of insurance company cannot be included on these Medicare bad debt. If it's inpatient related, not gonna count. You must try to collect from 120 days from the date of first bill, not the date of visit, but the date of first bill. So you'll keep up with the first day you send a bill out to that patient. Again, you must treat everybody the same, and you don't have to turn patients over to collection agency, but you got to treat everybody the same. And if you're still trying to collect that money from that collection agency, then you can't claim it on the cost report. Your collection efforts must cease. So that's your Medicare bad debts. There's a special form it has to be on, an Excel spreadsheet to them. Medicare will make us do that. I know Trent and Grace, another one of our interns, they spent all summer working on a Medicare bad debt listing for one of our clients, and it was no fun. I think it's $40-something thousand worth of bad debts there. So there's your Excel spreadsheets to do that. There's your MCREF stuff. Danny, do we have questions out there?
We do.
Okay, let's have some questions. And if you want us to open up your line, we can do that as well.
Okay, the first one comes from Nina. It says, for Medicare Advantage plans with Medicaid as secondary, if the Advantage plan does not pay the cap, do we write off the balance? Also, if the Advantage plan does not pay the admin fee for flu, do we write off the balance?
Yeah, the thing about Medicare Advantage plans is they're not really Medicare. They're treated as if they're just a commercial insurance. And when we talk about billing, well, about the golden rule, he who has the gold makes the rules. And those Medicare Advantage plans can pretty much do what they want as far as that goes. So you just have to work with them. You're not going to be able to claim any of that stuff on the Medicare cost report as a Medicare bad debt or any additional money for that, because again, it's not Medicare Part A. That's the only thing that goes on that cost report as far as Medicare goes. So you just have to work with them. You'll end up writing those off 99% of the time. Okay, next question.
The next one is from Edith. It says, do we use Danny's email to add her? I'm assuming you're talking about for the authorized user or authorized cost report preparer. And I've actually signed up through the portal under my email address. So you can try adding me. If not, shoot me an email and we'll try to work through it together.
Okay, good.
Danielle says, the provider we submit to Palmetto is not a provider for Medicaid. Would we still adjust that non-payment as an expense?
Okay. Say the question one more time.
The provider we submit to Palmetto is not a provider for Medicaid. Would we still adjust that non-payment as an expense?
As that non-payment? Yeah, I don't know. I don't understand the question, Danielle. If you'll email me that question, try to give me a little bit more detail, because I'm not following what the question is. Danny, can you figure that out?
I don't know.
You don't either. Okay, good. I'm not. Sometimes I'm a little dense, or Daniel, you just call me on that one and see if I can understand it.
Oh,
okay?
She did say example, deductible, or co-insurance.
Example, deductible, co-insurance. Okay, so I'm still not following the question.
I think she said, I think if I put that together, hold on, she's still typing. Okay. The provider we submit to Palmetto is not a provider for Medicaid. Would we still adjust the deductible or co-insurance that Palmetto would not pay as an expense? Danielle, I think that's how I'm supposed to word it. If not, let me know.
Okay. Yeah, I mean, whether they're Medicaid or not doesn't really matter, whether they accept Medicaid or not. I mean, I would think as a rural health clinic, you'd be accepting Medicaid. I mean, what you can put on the Medicare bad debt is, if there's that copay or that deductible is not paid, it has to show up on a Medicare Part A remittance advice. If it's not on that Medicare remittance advice, then it's not going to be paid to you as a Medicare bad debt. So in this case here, you have what's the new number for 2020? It's $197, $198 deductible. I come in and I go to y'all's clinic, and you don't, I don't pay that $198 like I should. You send me all the documents. It doesn't matter if your physician is on Medicaid or is accepting Medicaid or not. If that $198 is not paid and you do those things that I told you to do, then we can put that on the cost report, and Medicare will pay you 65% of that number. Does that make sense? Okay. Danny, do you have another question?
Yep, there's another one from Belinda. It says, if Medicare leaves a $38 copay and the Medicare supplemental plan also applied payment to the copay, is it considered Medicare bad debt if the patient doesn't pay?
Whatever portion that you don't get. I mean, if the Medicare secondary payer pays you, the full 38, then obviously there's nothing to claim. If that Medicare secondary payer only pays you $20 and they should have paid you 38, then that $18, again, you're going to have to try to collect that from that patient. And so you have to go through that same process. So that $18 difference there could be a Medicare bad debt. Again, you sometimes you tend to have to, I mean, if you send a secondary and they still haven't covered it all, a lot of times you just end up writing those off and just forgetting about it, because you end up creating such bad blood with your patients that it's not worth that sort of negative goodwill that you get. But in theory, if you tried to collect it for that amount of time in the 120 days, then you could collect that. Or you could put that on the Medicare bad debt listing. Okay, next question.
That's all we got.
Okay, all right. And then let's see here. Do we have anything on any hands up? I don't see any hands up. Okay. All right, everybody. Well, thank you all very much for your attention today, and we appreciate you guys very much. Again, we have this recorded, so it will be posted on the RHC group, Information Exchange group as well. And that way you can go back and listen to this amazing webinar. Danny, thank you. Trent, thank you. And we will talk to you guys later. Thank you. Bye-bye.